So good morning everyone. Today I'm going to be presenting in behalf of Medicine 4. So topic for my case is mind in crisis. So Mr. X, a 70 years old gentleman, presented to our emergency department with unresponsiveness since 1:30 p.m. History of presenting illness. His family saw him lost well at 12 p.m. So and he was unresponsiveness with frothing of mouth, and he also had bowel and bladder incontinence. And his family members found 3 by 4th of the monocotrophus bottle empty, and then he also had increased oral secretions with difficulty in breathing. Treatment history: he was immediately taken to a local hospital. Within 1 hour of his family members seeing him unresponsive, gastric in the local hospital, gastric lavage was given, and he was treated with atropine and pralidoxim, and he was referred to CMC on the same day, and he was intubated in the outside hospital as well. So vitals at outside hospital was pulse rate was 108, blood pressure of 160 bar 100, and saturation was 88 percentage, and the respiratory rate was 22 per minute. Vitals at CMC on arrival was pulse rate was 104 per minute, blood pressure of 150 by 80 with saturation of 99 percentage with adaptive pressure ventilation or synchronized intermittent mechanical ventilation, and respiratory rate was 20 per minute. So CNS examination, the level of consciousness was 2T by 15. The cranial examination, second examination, pinpoint pupils with fixed and non-reactive pupils, and ninth and 10th examination, there was absence of cuff reflex, and then deep tendon reflex, there was a reflex here. So the differentials were so the main diagnosis was deliberate synform OPC poisoning, which induced acute cholinergic crisis, and other differentials which was considered were hypoxic ischemic encephalopathy and persistent non-convulsive status epilepticus. So the investigations which I sent were CBC, hemoglobin was 16.4 with total counts of 20,500 with neutrophilic predominance, and LFT showed a total bilirubin of
You
0.
can just highlight the abnormal investigations.
Okay.
Anything you want us to note, you can tell us.
Yeah, the cholinesterase levels were sent to confirm whether it was an OPC poisoning, and it was 266, which was low. And then, since he was unresponsive, MRI brain was done to rule out hypoxic ischemic encephalopathy, and it showed age-related parenchymal volume loss with ex vacuo ventricular dilatation. And in order to rule out persistent convulsive, non-convulsive status epilepticus, EEG was done, which showed a minimal bihemispheric slow wave disturbance. So, and the course in the hospital, so atropine infusion was started, and the patient had persistent low sensorium. On day 10 of a post ingestion, his sensorium improved to GCS 10T, and day 15 post ingestion, his neck holding time improved, and the patient was extubated to NIV. And first, the initial weaning was failed, and later he was gradually weaned off to room. So, what was the reason for persistent low sensorium? The persistent low sensorium was because of delayed organophosphorus encephalopathy. No, that MRI was done actually to rule out hypoxic ischemic encephalopathy. No.
What did you just said, right? What is the diagnosis you're saying?
Delayed
Delayed, no? Delayed. It means, what does that word delayed mean?
So it was delayed. I mean, it was after some time.
In your patient, it was not after some
No,
time.
the initial low sensorium was due to actually to acute cholinergic crisis, and then since there was persistent low sensorium.
So, in a delayed OP encephalopathy, the patient will have a normal sensorium after the initial cholinergic crisis. And it is only after day 5, day 6 that they again become unconscious. Okay. So, and that is when you consider this diagnosis. Apparently, your patient had a GCS of
2 by 15.
From this beginning, right? There was no improvement.
No.
Am I right? So it's difficult to consider the diagnosis here.
Was he sedated? Was he sedated? Did you check the charts for sedation?
It was not.
No, he was intubated. And he was in our ICU, right?
Yes, sir.
Was he sedated? Is my question. You didn't look at it.
Yes. Yes. So. No, sir. Like he woke up only after day 10 of. No, sir. That I clearly don't know. No, sir.
And when was the MRI done? On which day of hospital admission was the MRI done?
MRI was done initially on the day of admission.
What was the indication for that?
So whether it could be like some hypoxic ischemic encephalopathy. Till no, sir.
Of absent cough and gag. When was that done?
No, initial admission
At
during
admission. Because what you're presenting, okay, usually this dope will present after a few days. When a patient who's woken up, then suddenly you notice he's becoming drowsy, has absent cough and gag, pupils are pinpoint. Okay, so you need to be thorough with the history. Okay, yeah. So we'll stop here. Let's go to the next person. Medicine 5, the effervescence